Good evening, everyone. I'm so glad you came back. A couple of you asked me, are we going to be crying again? And I said, I think that we're going to take a week that's gentler than our first session was. I promise that we will be crying next week, so you can anticipate that. You can't talk about death, and you can't talk about the process of dying and anticipating what that will look like for you or for your loved ones without having some emotion. And of course, that's only because we love so deeply, and we are deeply loved. So that's a beautiful gift. I have just a couple of quick announcements. First of all, last week, if you weren't here, we showed the DVD called Being Mortal. If you missed that, you have two ways to access that. Number one, you can go online, Google PBS, as in the television, PBS, and then Being Mortal, and you can view it for free on your laptop at your leisure. So that's one option. Option number two is I have a copy of the DVD here, just one, and I'm happy to loan that out as long as you are efficient about bringing it back. So I'd prefer that I didn't loan it out to you and you kept it at your house for a week, but if you can, you know that in the next 48, 36 hours, you've got time to view it, it's all yours, and then bring it back and we'll make it available to the next person. We are tonight live streaming our experience, and we're making a recording of it, and we will do that next week and the week after. So if you happen to miss a week or you're unable to be here and you're available at 6:30, you can Google, you can grab one of these that tells you how to pick up a live stream. If you're not able to live stream but you want to watch it, on the inside, it will tell you how to do that, and Kate Sterner in the office is going to set up a whole little folder for us. That's the End of Life series, Living Well for All of Our Days. So you'll be able to find that folder, and there will be 3 series sessions that you can take a look at. We have the resource table, as I promised last week. There's new material there. Please stop and take a look. There's some different books that you might be interested in. 2 in particular. One of them is this book, which has given me great joy. It's called Can't We Talk About Something More Pleasant? It's done in cartoon format by Roz Chest, who writes for, or is a cartoonist for The New Yorker. And it's based in real life. It's about her parents. Her father loses his memory. Her mother becomes ill, and it's this long journey of, as an only child, sort of preparing for death with them. There were parts that will make you laugh out loud, and there are parts that will make you cry. It's tender, it's lovely. I have 3 copies, so $15, first come, first serve. You can see me afterwards if you're interested in that. And then secondly, our guest tonight, who you will be introduced to in a moment, recommended a book that I went out and bought immediately. It's called Living Glory.
John Dunlop?
Yes.
Oh, isn't it?
It's a very good book, John Dunlap's book. You'll see it on the table. Take a look at it. It's filled with scripture. He's an MD. Filled with scripture, so it's a really interesting and helpful read. So take a look at that, and you can order a copy for yourself if you'd like. We have take-homes every single week, so if you didn't catch the take-home last week, it's on the table in the back. And when you leave tonight, there will be a take-home that you will not want to miss. This take-home tonight is going to be something that you're going to tuck away and you're going to be glad you have someday. We'll tell you more about that at the end. We're going to use the Faith and Life model for our time together tonight. In a moment, we'll have some devotions. Our speaker will be introduced. He'll talk for about 40 minutes, and then we'll do a Q&A for about the last 15. Does that sound good? Last thing I have to say to you is there are white index cards on the table out there. If you have a question that doesn't get answered, or we run out of time, or that's too personal, feel free to write a question, leave it in the red box on the table as you leave, and we are collecting them and organizing them, and we will respond to them at the appropriate time. So, having said all that, I'm going to turn it over to Susan Path, our parish nurse, for our devotions.
Thank you, Cheryl. Welcome, everybody. I get the handheld, but I'm not going to sing. Last night I thought I should be like a lounge singer, I felt like, with this. I have the devotions tonight, and so we'll, confronting our own death is what it's called. All of us spend some time, some more, some less, in contemplating death. We have to. We're all dying. Death is real to each of us, It can't be bought or bullied, coaxed or frightened. It is there. No clever cosmetics can cope with it. Like most people, I am arrested from time to time by the thought of death and eternity. I recognize sometimes as the stirrings of God's Spirit at my heart's door. In earlier years, I thought most often of other people's deaths and seldom of my own. In later years, however, I am consciously under God's searchlight, sometimes in seclusion and sometimes in the fellowship of others. Anxiety is inevitable. Don't make it worse by deceiving yourself and acting as if you were immune to inner trepidation. God does not ask you to feel anxious, but to trust him no matter how you feel. These words from the pen of the late Thomas Merton help me to be honest in dealing with my fears. I used to speak of making friends with one's dying hour. Today, I will not say this. Death is our enemy, the only enemy to be encountered. Someone has come who could tower over death and command it. Someone has truly to enter into who could break its power by rising again. But it had to be real death. No sham battle, no counterfeit experience. And so Christ came to die. This was his errand. It was as an arch enemy of death that Jesus died so that we might be with him forever. Jesus breaks trails into the unknown. His mercy lights the path through the years ahead and through the moment of dying. His mercy is the path. I remember 2 words spoken in the stillness of a hospital room. A note left in a church office summoned me to a local hospital. A young mother had lain for some weeks succumbing to the dreaded disease. I had administered word and sacrament to her there many times. For 12 hours now, she had not spoken or seemed to recognize anyone and appeared to be in a coma. There seemed only a slight possibility of getting through to her. However, I bent over the patient and slowly spoke several passages from the scripture. To my amazement, she aroused herself and spoke 2 words. Repeat them. In her extremity, this child of God did not ask conversation with fellow persons. She sought it with God. We didn't faint with fear. We needn't faint with fear if we know who and whose we are. Jesus died for me, and now I dare to face the dark fact of my personal death. I'll say it till I die. Lord, I believe, help my unbelief. We will always be surrounded by gentle reminders of our mortality, the march of the seasons, the snow, the changing colors and falling leaves. Whether we are young or old, our time's in God's hands, and we are wise to leave them there. That was the words of Gerhard Frost. And so we'll pray, say a small prayer. Dear God, be with us today. Thank you for letting us gather here in your name, and also looking at the death of Christ and how he has saved us to help us see how our path ahead and our death will be changed, forever changed by these moments today. Be with our speaker today as he leads us through the thoughts that will help us travel these next days. In Jesus' name, amen.
Dr. Struve has worked 43 years in clinical hospital medical care, both at Bloomington Lake Clinic and Fairview. He completed a Master of Science degree in clinic research at the University of Minnesota and published a book in 2013, The Trajectory of Illness and the Mystery of Healing, concerning the health and healing of the human spirit. Most impressive for him in his practice life and learning has been the way his patients have found manageability and strength, purpose, and hope in dealing with their pain, disease, or dysfunction. Dr. Struve is married. He has 3 daughters and 5 grandchildren and attends church at Trinity Lutheran at Minnehaha Falls. In the spirit of Pastor Tim Westermeyer, I asked Dr. Struve if he could offer something that he'd want to share that we wouldn't otherwise know about him. And he said, one thing you don't know about me is I am in the 2nd semester of going back to the University of Minnesota, 3 credits each, Monday and Wednesday. I go by light rail. Last fall, it was public writing, and this semester, literary journalism. It's me and the savvy millennials. So please welcome Dr. Struve.
Can't hear you.
Oh, a red light. Does that mean, Cheryl?
Nancy's, we're going to start.
He's got it.
No.
He's on it.
But he has it. I'm here for a few minutes.
Yeah.
That's for you.
Yeah, I think. Yeah. I'm auditing that course at the university, and it's 17 students and me. And, we have a very quiet relationship. I've talked to the teacher, and she's wonderful, and I love the course. But I'm not sure she knows what I'm doing there. And I'm afraid that I'm actually doubtful that because I'm afraid that she has learned that my almost absent participation in the discussions and absent participation in some of the legwork is that I have no more knowledge of journalism than these millennial 17 students that have walked into my gross anatomy lab for the first time in medical school. And I don't. But it's a wonderful opportunity to be there and to get back to the University of Minnesota. So thank you for coming. And thank you for the opportunity to be here. I go to the Faith and Health and Life meetings here. And it's a wonderful congregation, it's a wonderful opportunity. And I know they partner with many other people also. So it's not often available to most of us. So thank you for that. The title of what I want to talk about today is How Do We Die in America? It wasn't my title. Susan and Nancy and Pastor Matheson met with me, and it was their idea. And I really, the more I've been thinking about it, I like it. I like the title. It forced me to do some different things and to talk a little bit differently. My perspective is purely as a physician. When we're dealing with the end of life, there are so many different ways that practitioners and healthcare providers can address this issue of how we die in America. I'm doing it from my perspective only. I'm a family medical guy, geriatrician, so I've been involved for many years. I was a 30-year medical director of a nursing home, Redeemer Rehab, Health and Rehab. And I volunteer and work at the hospice and palliative care unit over at the VA and have for the last 3 or 4 years. So it's really been a delight to talk about this. From my perspective, if I had a different set of eyes, you'd be hearing a social worker. And they would have something profound to say about what we're going to talk about, but it wouldn't be from my set of eyeglasses. If it was a nurse practitioner, or a parish pastor, they would have their own set of eyeglasses to look at how we're talking. So you're going to get me from my perspective. tonight, and that helps, and I think that's why it sort of helps. I want to talk about 1967 a little bit. I want to talk about the medical revolution that we're sort of experiencing in the last 10, 15 years. How do we as physicians categorize you when you come in to see us? As in the clinic, or in the emergency room, or in the hospital, or in the intensive care unit? How do we categorize you? We need to categorize you in some way, knowing what we know about not only the demographics of our country, but also the sophistication of care that's evolved. Shifting gears. How do we shift the gears from wanting full select treatment of technology, select treatment with limitations, and comfort care orders for, as we've talked about in the news media recently? How do you do that? How do you shift gears like that? How do we, as providers, do that? Where do we die? When do we die? How do we do that in 2018? And which doctor will be caring for you at the end of your life? That's a big issue too. We'll talk a little bit. So I'm going to go back to 1967. 1967 bookends for me the contemporary medical response to the end of life. 1967 does that. It happened at St. Christopher's Hospice in Sydenham, England, and it happened by a lady, Cicely Saunders. And so that bookends from that point to right now, tonight, the way I see the medical response to end of life has been. You know, there were Christian hospices historically for years and years and years, but really Cicely Saunders and St. Christopher's really bookended for all of us the vision that she had for end of life. And I want to discuss that and where we've come from there. In 1978, I visited St. Christopher's, some of us did, in Sydenham, a suburb of London. We listened to a series of lectures by Dr. Saunders. She was credentialed as a nurse, credentialed as a social worker, credentialed as a physician. So she had 3 credentials. She is now known as the mother of the hospice movement, but had the vision for what that meant. We did get lectures from her. I remember her sort of like a mothering eagle. She had darting eyes, and she was sharp as a tack, and had a sharp nose, and talked about terminal cancer. She talked about some experiences she had, and she laid out her philosophy and her vision for that care. I remember 2 short phrases that are quotable for Cicely Saunders. One was that we care for persons with compassionate matter-of-factness. I think that's quoted from her. And the second thing was that she said, our vision here is that hope springs from reality faced straight. And that was Cicely. Now, 50 years later, we're in the midst of a medical revolution, aren't we? There has been a dramatic change in the demographics of society, but more than that, the sophistication of care that we're getting. We live longer, we diagnose and treat patients with less pain than the last 40 years. I can tell you that as a matter of fact. We plant stents, we transplant organs, we replace most joints. We do surgery laparoscopically and robotically. And now we're seeing that genetic editing and new cancer technologies are just mind-boggling And if I was going back to be a physician, I might be an oncologist. It would be, it's such a progressive thing that's happening right now. And also innovative artificial intelligence will change the kinds of specialties that we have in medicine. So that's where we are here. And yet, there's this problem of complexity. Complexity for both patients and for health providers. At the most, it's confusing to both patients and providers. We have 6,000 drugs. We have 2,000 surgical procedures that you could be recommended as having. Who's running the show? Is it the industrial medical complex? Is it the insurances? Is it the MBA administrators? Is it the health providers themselves that are running the show? Alarming. In fact, we're sort of haunted by this health system. Haunted by it. At its worst, it represents more human error. It's just so complex. There's so many specialties. There's so many places we have to go to get care. And at its worst, it's broken, isn't it? So we're there. And yet, that's not all of it. We have alarming healthcare disparities that exist within gender, within race, within age, within disability. So that's what's happening. So we have a yay and a boo, don't we? Medical revolution and a lot of things that we're haunted by. How are we going to fix the complexity of it all? So my sense as a physician tonight, and I'm telling you just from one perspective, is that the end of life is primarily a family, not a medical thing. And I'm going to try to show that in a couple comments that I make. Yes, we have the medical, we have the complexity, but with the vision that we've had for responding capably with end-of-life pain, anxiety, delirium, nausea, sleep, and all the things that happen at the end of life, we're fully capable of dealing with those for the most part. And but things have changed a bit. My dad died several years ago. My mother died about 4 years ago. There are different ways that a heart can fail. My dad died of diabetes, 35 years of diabetes and age, basically. And most people with diabetes that haven't been going on for 35, 40 years is a substantial risk for increased heart disease. And so I remember several times that I've been at the hospital where almost everybody was a diabetic. 7 people, 10 people, and all of them were diabetic. That's a different subset, isn't it, in one sense? So that's one of the issues. That was not my mother's. That's not what she died from. She had a structural heart problem. The heart, when we get old, and she was 92, the heart can either become floppy and become ineffectual with what we call a low ejection fraction, or it can become stiff and unable to function. And so my mom died of a stiff heart. She wasn't stiff personally, but it was a stiff heart. And it just was a very slow process over several months, a couple of years, actually 3 years. Finally, she broke a hip, went into where she didn't want to go, skilled nursing facility, and found that was just the right spot for her, actually. Even though my sister was there in our hometown, my brother was too. That's the way she wanted that. So I would talk. We had many conversations. We talked about being afraid. I remember that. I remember how she acted. We were all there when she died. The prayers, the music, the place, the waiting, and the mystery of it all. Henry Nouwen describes profoundly in his book, The Greatest Gift. He said, when he simply states, we are parents of generations to come. When we think about death, we often think that about what will happen to us when we died. But it's more important to think about what will happen to our family after we have died. What will happen to those we leave behind. The way my mother and father died had deep and lasting memories. I mean, I can remember, all of those details. I'm sure many of you can do that same thing. It's a very memorable experience, but it's a family event when possible. And the medical event, for most of us, is secondary most of the time, and I'll try to identify that. About 20% of us die unexpectedly and abruptly. So if you talk to an EMT, they would remember those people, perhaps more than I do. 80% of us are usually under the care of a health professional in the United States. 50% of us are unconscious. I can tell you that that's the case every time I go to our hospice and palliative care unit, that most of us, 50% of us die unconscious without being able to make decisions for ourselves. So we do need a health agent in that case. 100 years ago, we died of trauma and infection and childbirth. And 50 years ago, we still were living less than we are now. Our average age now is for men it's 79, and for women it's about 82. So that's, and my definition of age is 85 or older. Maybe it's because I'm getting older, but I keep expanding it up. But that's always been the case. I believe 85 is the right age. Then you can say you're old. Now, some of my people, they're 74, 84, and they're just, they know they're going to get old, and they get a little worried about that. But thankfully, an 85-year-old woman has a life expectancy of about 7 years. And 90-year-old woman would have a life expectancy of about 4. So the idea of they're dying within a year is not really true, is it? There's still, if they get that far, there's something about them that either their lifestyle or what they've been doing, how they've been taking care of themselves, or just genetics, or just good family. 20% of us die of heart, lung, or kidney disease, so that's a big issue. 20% of us die of terminal malignancy or progressive neurological dysfunction. And guess what? 40% of us die of frailty. We just die. I mean, that's just it. I mean, and what is frailty? Well, my definition of frailty is that it's not just age. Age is the factor. Age is the factor. A 90-year-old person is impacted by illness much differently than a 50-year-old person and a 60-year-old person. So, but what we're seeing is that those 40% have 3 things: functional impairment, and that is, they cannot, because of their aging, function independently. They cannot function. They can't deal with the variables that have to do with just getting along at home, and so they need either assisted living or long-term care, and so that's the way we die. That's from a physician. What are the categories the physician has to deal with you? Well, we categorize people in 3 ways. This sounds awfully objective, and there's a lot more to being to determining this. It has to do with the relationship. One of my mentors said that there are three things that happen when you go into the exam room with the doctor. One is what's happening to them, and what you think is happening to them, and the relationship. And so there are three things, and those three things are very important. That relationship is very important. But anyway, CPR is not as helpful as we think. It's not as helpful as what the movies tell us. Approximately 1 in 5 patients, that would be about 20%. The data is highly variable, because when you look at the American Heart Association, you look at CPR statistics, it depends a lot on who is witnessing it, what type of an event happened. Did you have a rhythm event, or did you just have an arrest? And there are a lot of other variables that have to do with it, but you're looking at about 17 to 25% of people that arrest in the hospital survive to discharge. 17 to 25%. So when you have a cardiac arrest, when you stop breathing, when your heart stops, that's a bad thing. It doesn't, it was started, when we were looking at people that got struck by lightning in the golf course, and they were 25 years old. But there's a lot of things going on with CPR, but right now it's about 17 to 25%. If you have an unwitnessed event outside the hospital, it would be more like 12% survival. So if you're lucky enough to be in the basketball court and there's a defibrillator right there, and there's someone that's going to compress your chest 120 times a minute, then you're blessed. But not like if you drop and you're out biking alone on a bike trail and collapse. The older, the weaker, the more frail we get, the less that risk is. I mean, as the medical director of a nursing home, we always used 3% or less survive an arrest. And so if you are functionally impaired enough to be in a nursing home, or nowadays we're using we're increasingly looking at people trying to stay out of a skilled nursing facility, so they go to an assisted living, and what happens is some of the regulatory stuff is missing there. So a lot of us don't want to get to the point where we are in a nursing home, but the risk of CPR is less than 1% in an unwitnessed arrest in a nursing home. Now, what's happening in nursing homes is we're getting younger people. So age is still a variable, but functional impairment is a variable, and having co-occurring illnesses is a big variable. So if you were to come into the emergency room and I didn't know you, and we didn't know, and we maybe knew that you had had a cardiac arrest or something like that, the three things that would be most important is: where did you come from? Where were you living? Were you functionally independent? Were you assisted living? Were you in long-term care? How functionally impaired are you? And how old are you? And how many co-occurring illnesses do you have? Do you have diabetes? Do you have hypertension? Do you have hypercholesterolemia? Do you have all these other things that we look at as risk factors? So the way we categorize you and me, because I'm a patient, we're all patients, aren't we? Are you full treatment? Do you go on CPR? Number one, when you come into my clinic, we always ask these things, because this has to do with health directives. And remember, if you just fill out your health directive when you're 40 years old or 70 years old, it's quite a bit different when you're 80 years or 90 years. So the health directives are meant to be reinvented and reprocessed with time. And then there's how prepared are we with this? do we consider preparation important? It sat on, Carolyn's and my wife's health directive sat on my desk probably 6 months before we said, oh, well, it's like paying your taxes. You know, you got to do it. And I'm telling everybody else, you know, but we took a long time. And then all of a sudden, whoa, you know, she thinks she values different things than I do. Didn't know that. You know, so there's some of the values and goals part of it are very, very, very helpful and are very revealing, actually. But how prepared are we? When I was a young physician, we delivered babies, and I watched scores of women labor. For some, like my wife, Carolyn, labor and delivery was steeped with meaning and purpose. We went to prenatal classes. I watched her change structure and appearance. There was no doubt that the labor and the birthing was a faith experience because we didn't know the outcome. So to her, it was a journey, and then she was the adventurous, wasn't she? She was the one that was the adventuring out. And we learned that usually, we learned what usually happened, and we took it all in. Some of my patients don't prepare as well. I distinctly remember one woman in great distress until one of us gently asked her and discovered that she thought that's what she was supposed to do. And when she found out that she didn't have to do it, she was to act the way she did, she stopped, and it was totally different. So preparedness is important. Many of you remember the prenatal, 1960s, when when women decided that they wanted to get out of the operating room and they wanted to start delivering babies in the birthing rooms. And that took about 30 years before the culture woke up on that. So 30 years later, now we have all birthing rooms. And that's, I think, what we're going to be doing, whether end of life as well at some point in time. We're going to understand that we need to demedicalize and relabel where we do it, how we do it, and when we do it. So I also remember an episode where one day I had a call from a young woman who was in labor, and we talked, and we tried to plan together about her coming into the birthing center. And after talking to her, I found myself the very same morning at a home visit in the apartment of an elderly lady, boxing up her clothes to move into her daughter's apartment. She and I both knew her terminal prognosis, that would be her final move, and I found myself watching her, the way she moved, and her eyes and her deliberateness, and she knew what she was doing. She knew who she was and the journey she was ultimately going to take. And she reminded me of that young mother who had talked just a few hours before that, planning for a labor. The single-minded preparation of both women was not lost on my remembrance. So there are a couple myths about using technology. Some, people do this, and maybe I do it myself sometime. But sometimes you think this in this sort of way. Well, if it's paid for, it's okay to use. I mean, that's reasonable. If it can be done, it should be done. That's reasonable. I mean, there's something about those two myths of using technology that make me pause a little bit. Is it always morally necessary to use technology? I don't think so. And in fact, I don't believe so. I don't think John Dunlap believes so either. The book that Pastor Matheson mentioned. So what about this technology at the end of life where you can choose to not use invasive things? We can choose not to use oral antibiotics if you're advancing dementia and the family and you and everybody has decided that this is where we want to go. We don't need tube feeding necessarily, because that's a nutritional supplement. When do we need intensive care stabilization? When would we use that? We're finding that the people that have captured their health directives make some different choices with these technologies. When to come in for intensive care, when to not use it, when do we have mechanical ventilation, when do we replace the defibrillators, the pacemakers that we had put in 10 years ago. Do we need to replace those at $40,000? Now that's not a cost item that you would be concerned, but I think about that sometimes because those are the kinds of talks, the financial talks that we only think about internally. And, but it's an issue with families. And dialysis, when do we do dialysis? And when do we do radiation and chemo? And to me, as a physician, I distinguish the words life prolonging and life extending. And the reason I do is I won't be able to communicate to you adequately, but I feel that when I think of prolonging life, I think it's just the life, the physiology only. Whereas life extending means that I'm looking for quality of life. I'm looking for a little more function, and I would fall into that category number 2 of selective treatments. So the first category is full treatment. The second one is selective treatment. I'm going to limit some things. I'm not going to buy that if it should be done, it can be done. If it's paid for, it's okay to use. I'm going to think more in terms of what I want, what's important to me, what do I value the most. And so the third category is comfort care focus. We just had that with Barbara Bush, didn't we? When we read in the Tribune that she decided she was going to select comfort care, which for me is a synonym of hospice type care, although hospice has become institutionalized. So since Cicely Saunders' time, the word hospice has some financial data. It's remunerated. So in one sense, to say comfort care focus is the same thing as you've decided on hospice. But hospice now has become institutionalized, and it's an interesting word. I still love it because I love Cicely Saunders, and I love the vision that she had for a whole person healthcare, and the fact that it's a collaborative approach, and the fact that family is the culture of orientation, not the medical care. But she was the one who figured out how to reduce the pain, improve the sleep, reduce the nausea, forget about the delirium, the anxiety, and the comfort, the anxiety, and the anxious. They did that. That's been going on for 50 years now. But so when do you refuse technology? John Dunlop does talk about that in his book, Finishing Well to the Glory of God. And he said there are 5 reasons to refuse technology. You can refuse it if it violates your wishes. You can refuse it if it's generally felt to be futile. You can refuse it if it's presented as effective, but it really isn't. You can use it if it's a burden of use is worse than the benefit. You can use it if it's disproportionate care. What does he mean? That Catholics have come up with that word disproportionate a little bit in ethics. I sort of like it. It means that using your own values, you consider it's either proportionate or not proportionate in what I want to do with my life. So, now, by the way, I've got all these little things that these guideline things in a PowerPoint. So we'll get them. We've got them if you want them. So you don't have to write them all down. John, in 150, page 159 of his book, I put down, he said, I'm going to tell you what I think. Now, John is an internist who I met down at the Mail Reviews. He's a wonderful guy. He's now at Yale. He's got a good guy. He's a good guy. And he wrote this good book. And he said, this is how I want to use technology. He said, I am happy for technology to be used so long as there is reasonable hope of it allowing me to serve others. But if for physical, mental, emotional, or spiritual reasons, it is unlikely I will be able to serve others, I do not want that technology. That's what he said. And I think he was going to Philippians, the first chapter, verse 20 to 26, something like that. That's really where Paul was writing to the Philippians, was telling him what he thought. You know, what should I do? Should I die? Should I go? Should I stay? Or what, and he sort of named that out, and John thought that was, Dunlap thought that was important. So what about shifting gears? And I call that shifting gears when we got to have that family conference about, my understanding of your illness. We set up a time, we have a conference, we get some family members together, we invite them to tell their perceptions of what they think is going on with their illness, and then I will ask them to see if they would be willing for me to share what I think. And then with that, we go to my understanding, and then some time to be quiet and see what happens emotionally, and summarize. I mean, that's sort of what we do with the family conference, and that's the kind of thing that I would have you expect to do if you're going from limited select treatments to I want to just focus on hospice treatment, comfort care measures to improve my quality of life with the time I have left. So, and Cicely, and now we're doing a better job. I think we can control pain less than 2%. I think we're down in our hospice program at the VA. I think my experience over 3 years is that we are able to manage pain well. And one of the problems in my nursing home has been that as we all go to, some of us are going to go to assisted living, some of us maybe go to nursing home, skilled nursing facilities. The problem is that even though we know how to do that well in a refined area like hospice and palliative care at the VA, some of the nursing homes haven't quite got there yet in knowing exactly the kinds of medicines that the 6 or 7 types of medicines you have to be around and know how to use them immediately and well. So I mean, we're still at a point, from my perspective, that we're not quite there, but it's push and shove, and we're getting there and doing better, and we're doing better. 42% of in 2009, 42% of people were using hospice, comfort care measures at the end of life. That was in different frames. Now, about a third of us, and we're doing better in the way where we go to die. In 2010, 70% of us were dying in the hospital. 2018, it's more like a third, 33%. So we're doing a better job in demedicalizing to a certain extent what's happening with healthcare at the end of life. So I'm about done here. So let's just summarize then which doctor will be there at the end. Well, would it be my family doc? Would it be my internist? Would it be my OBGYN? Would it be my pediatrician? Who would it be? One of my friends, David Brown, said, go to the one where when you came to see her, she listened or he listened. You go to that one. Go to the one that says, I'll tell you what I don't know. I'll tell you, I'll be truthful, I won't lie to you, and I won't abandon you. So that, in Paul Kalanithi's book, When Breath Becomes Air, his oncologist was the person that really supported him all the way through that novel. So it could be the oncologist, it could be the primary care doc, whoever listens the best and is interested enough and to be around. And then geographically we move a lot, don't we, as we get older. We move to children, closer to children. We move from one area of the town to the next. We might go to an assisted living. So there's a lot of movement that happens. We try to decrease a lot of that happening, particularly the kinds that we're in error of. In other words, we send you home to the nursing home first and then have to send you back to the hospital, and all this sort of transitional care stuff is sort of a problem. And we've got a lot to gain. As physicians, we've got to really be much more attentive of how we're processing that. But anyway, so there's so much to talk about. I don't think that we've even scratched the surface, but why don't we, some questions?
Perfect.
Or time for that. I went a little over, I'm sorry.
We've got a couple of microphones, so if you have a question, you can raise them. And as you're thinking about your question, I'm just going to note this. As he was talking about moving from the birthing room perhaps to a dying room, there was a really interesting article in the Blizzard Days newspaper on Sunday. Did you see it in the variety section about having doulas, death doulas?
Yeah, wasn't that was
who
good.
will walk with you and journey with you at the time of death. So when you were answering this last question, who's going to be with you? What medical person is with you? One of the things that article suggests is having a doula guarantees that you get some consistency. That person will be with you even as
I thought it
perhaps
was good. I thought
your
it was good.
caregivers change. So questions?
Is it going to be free? That was the question I asked. That,
Would that be nice? Nothing is
well, they
free.
should. I mean, traditionally they're supposed to
They
be.
totally should. Okay, we've got a question back here.
We see a lot of the news about medical marijuana and how that's helping pain. Is the medical profession looking into that at all for end of life?
Not at my hospice and palliative care unit, we haven't. That's as far as I could go. That's at the VA. We're not using it. And I know the medical director, and I've talked to him about this, but part of it is evidence-based. When does it help and when is it not? We're getting so many good responses that it's helping that one really makes all of us wonder, doesn't it? But the answer to the question, my knowledge wouldn't go beyond where we're doing that at end of life.
Another question?
Good question.
Yep, here we go.
Bruce?
We talk a lot about the quality of life, but I never hear anybody talk about the quality of the training of the doctor. As I approach the end of life, the advice that I'm getting from the doctor, is it any different if that doctor's been trained at the Harvard Medical School or the University of New Mexico or Mayo Clinic or the Cleveland Clinic? Do I want a doctor that has been accepted at Harvard versus somebody who graduated with C's at North Dakota or something like that?
Well, that's a legitimate question. If you just only read the New Yorker, you'll probably go to that Harvard doctor. But I think that, I've never, I went to my Carolyn, when was that, the 45th year medical reunion at the University of Minnesota. So we had about 300 physicians in our practice. I mean, in our class. Yes, class. And so at about 45, and we each spent 5 minutes to talk. And I was never more proud of those 45 guys. I'm proud to be a physician. At the University of Minnesota was great. And I went back, got my master's in research and clinical research there also. And I mean, you know, and we had some people from Harvard University there too. I mean, I don't even think of that actually in myself as although I think I would probably ask my friends who's a good internist, who's a good family doc, who's a good, you know, geriatrician. And I've found that helps as much as anything in terms of knowing your friends and knowing where they're going for their care. But what was your thought? Did you think that made a big difference? In terms of credentials?
In my career, there were clever people that were better at what they did than others.
Yes.
I'm an admirer of excellence.
I know, I am too.
I have a hard time reconciling with the fact that I might be being administered or being treated by a doctor that's not in the top 5% or 10% of it.
Yeah.
So let me repeat what Bruce is saying so you can hear. In response to Dr. Struve's question, Bruce said, I'm an admirer of excellence, and in my career, it mattered, you know, the degree and your performance. So that's where the question rises from. Any more questions? Okay, so a couple of things. One, you have index cards. If you want to write out some questions, feel free to do that and leave them in the back. Secondly, Susan is going to do sort of a what's next and give you a heads up for what's coming next week. And again, don't leave without grabbing the take home. I'm going to head back there for that. And in the meantime, Dr. Struve, would you stick around for a couple minutes afterwards if people wanted to approach him individually? And then would you just join with me in giving him a round of applause, thanking him for his time?
Thank you.
Thank you, Dr. Struve. That was very helpful. So as you leave, the resource table is over on the left here as you exit. That has the book that they were talking about. Dunlop is on that. Also, if you look in the back of your binders, there is a resource tab, I'm not sure what color it is. The book Breath of Air, is that the? When Breath Becomes Air is listed on there, and there's other ones listed on there besides Being Mortal. So if you are interested in reading some more, those are on there. And some of those may be on the back table and the resource table also. Leave your questions once again if you have in the red box. I noticed there is some in there. The one that's in there right now will probably be answered at the 4th session. And your take home today is a book that Pastor Matheson really enjoys or thinks is great resource. It's called Afterwards. It's a Helping Yourself Heal, and it is about grief. So if any of you have lost a loved one, it's a resource that's very good for that, and it's not long. It's an easy one to get through. So that's there for you this week. And next week we have something really great for you. And speaking of next week it will be our privilege to have Annette Langdon, who is an RN from the Fairview system, but she is also a deaconess in the Lutheran Church with us, and she is the training person for Fairview on healthcare directives and honoring choices and advanced care planning, and so she will be with us. She has a wealth of knowledge in that, and I will be helping her lead that session. Nancy Fabian is also trained in honoring choices and healthcare directives, so she will be here also with us next week. So I hope you can all come back next week. He did mention healthcare directives, so if you look in your section of the binder, there is a section for that next week, and you can look through that. There is 1 or 2 more pages that we'll add to that next week. So if you want, you can look through that. Thank you all for coming. and enjoy your week. And if you have any questions, we'll be out there in the back. Cheryl has some of the afterwards to hand out to you.